my name is David Graham. I'm an upper GI specialist at University College London Hospital, and I want to talk to you about my 4 top tips for placing an oesophageal stent. Tip number 1, never predilate the malignant stricture. There is no need to predilate the stricture no matter how tight it is. Provided you can get a wire across the stricture, then you will be able to deliver the stent. The stent devices are thin and tapered and will pass through the stricture fine. Predilating the malignant stricture will increase your migration rate of your stent and thus failure to palliate the patient's symptoms. Tip number 2, ensure that you pick the correct wire. You want to pick a stiff wire that allows the passage of the stent through a tight stricture. However, there are also wires that have a soft or flexible tip that will ensure that the wire passes easily through the malignant stricture and of course decreases your perforation rate. Personally, I often favour the Boston Amplatz wire as it is stiff but has that flexible tip. When positioning the wire, it is also important to ensure that the wire is straight and into the distal stomach. It is very easy for the wire to coil up in a hiatus hernia or coil up perhaps in the fundus of the stomach and then come back towards the stricture. Without having a straight wire into the distal stomach, one does increase the chance of there being a perforation with a poor position of the esophageal stent. Tip number 3. When positioning a stent, it is important to know the exact location where you want the top of the stent to be. The best tip I can give for this is to use both your experience with your X-ray as well as using a contrast bleb. The best thing to do is to position your scope either at the top of the tumour or exactly where you want the stent to be placed, and then X-ray at this time so that you can get an anatomical landmark using the vertebrae to see exactly where you want to place the stent. You should then copy this picture, or at least remember this picture so that you know exactly on which vertebrae you want the stent to align to. In order to further improve the accuracy of your stent positioning, the best thing you can do is inject 1 ml of contrast into the esophageal wall. This contrast bleb will dissipate, but it should stay in position long enough for you to be able to place the stent accurately. Using the radio-opaque markers on the stent, you should aim to align the very top radio-opaque marker with your contrast bleb. That will then ensure that your stent is placed in the correct position. Final tip, tip number 4. The stent size is of course important. One should ensure that there are at least 2 centimetres of fully expanded stent on either side of the lesion. Thus ensure that the length of your stent is adequate to cover this sufficient space. It is also worth noting the diameter of your stent. Each manufacturer produces stents of different diameters, and certainly when one is considering tumours that cross the gastroesophageal junction, it is worth considering a stent with a wider diameter to hopefully decrease your migration rate. So, in conclusion, my 4 top tips are: 1, never predilate the malignant stricture. 2, ensure that you choose the correct wire and position it correctly. 3, ensure that you have correct position of your stent using your experience with X-ray and aligning with the vertebrae as well as a contrast bleb. And 4, ensure you pick the right stent so that you have sufficient coverage over the lesion. There are fixation devices available that are aimed at decreasing migration rate, a particular problem with tumours that cross the gastroesophageal junction, and we'll discuss these in our upcoming Gastro Learning live event coming up soon.